Okay, good morning, guys. So today I'm going to talk about two of the very important topics from adrenal gland. They are Addison's disease and Cushing syndrome. Okay, so we have done diabetes in the last class. Now we are entering into the adrenal gland disorders. Now, to start with, a little bit of anatomy and physiology, as always. See this. Adrenal gland are also known as suprarenal gland because they are situated at the top of both kidneys, okay, right and left. Now see there. Regarding the blood supply of suprarenal gland, a common question is asked because it is very richly supplied with blood vessels. There are three arteries which mainly supply the suprarenal or adrenal gland. They are superior suprarenal or adrenal artery, middle suprarenal artery, and inferior suprarenal artery. Please mute yourself. And inferior suprarenal artery. There are three. The superior suprarenal artery are coming from inferior phrenic artery. This inferior phrenic artery is the artery of diaphragm. Phrenic is the term for diaphragm. And many of the time it directly comes out from abdominal aorta. And sometimes, okay, it comes from celiac trunk as well. Middle suprarenal artery is a direct branch of abdominal aorta, and the lower or inferior suprarenal artery is a branch of renal artery. That's how adrenal glands are supplied by the arterial circulation. Now, the more important point here is histology. When we cut this adrenal gland, okay, as a transverse section, see this. These are the parts. The outermost covering is called capsule. The outer layer is called cortex, and the inner part is called medulla. Just like any other organ, these are the very common terms. Now, this cortex of the adrenal gland has got three zones. These are called zona glomerulosa, zona fasciculata, and zona reticularis. Zona glomerulosa, zona fasciculata, and zona reticularis. We are going from outwards to the inside. And this is medulla. This medulla has got specialized type of cells which are called chromaffin cell, and these chromaffin cells are modified form of sympathetic neuron. So they are responsible for the secretion of catecholamine like epinephrine and norepinephrine, whereas these three zones from the cortex are responsible for secretion of different type of hormone. Okay, now let's talk about what are those hormones. See this. This is absolutely basic knowledge for all the students. Okay, I am sure many of the students already know this, but if somebody still doesn't know, then please listen properly now. See this. Adrenal gland is cut, cortex outer part, medulla inner part. This is the histological appearance. Zona glomerulosa, zona fasciculata, and zona reticularis. These are the three zones of cortex, and this is medulla. Now, these are the hormones which are released from zona glomerulosa. Mineralocorticoids comes out. So, mineralocorticoids, and the most important mineralocorticoids is aldosterone. Aldosterone. Remember the name. Glucocorticoids comes out from zona fasciculata, and okay, the important glucocorticoids is cortisol. Others are not very important for you. Cortisol is the most important one. Other are corticosterone and cortisone. Okay, other forms. From zona reticularis, we have androgens coming out. Androgen, okay, are also known as sex steroid. Dehydroepiandrosterone and androstenedione. These are the two important ones. Dehydroepiandrosterone and androstenedione. So these are the example of androgen. Whereas from the adrenal medulla, we have got catecholamines, okay, also known as stress hormone. But this is a bit of confusing term because sometimes stress hormone means cortisol as well. So better to use the term catecholamine like epinephrine and norepinephrine, or also known as adrenaline and noradrenaline. Okay, very easy, knowledge, because many times we have repeated this in the past as well. Let's move on. Now, what are the actions or functions of glucocorticoids like cortisol? Okay, so let's discuss about that before we enter into the medical aspect. Cortisol is the naturally occurring glucocorticoid. It's the most important glucocorticoid which is secreted by the adrenal gland. They act on intracellular corticosteroid receptor. Now, where are these receptors present inside the cell? Where exactly? Yes? Anybody?
Intracytoplasmic.
Nice. Very good. These are present on the cytoplasm. They are intracytoplasmic receptor. So they act on the cytoplasmic receptor, and then the whole complex will enter into the nucleus. Okay, and then it acts on the gene and cause transcription. Okay, then translation, then new protein synthesis, new enzyme formation, and that's how it modifies the function. Now, let's talk about the actions of glucocorticoids. These all of the functions or actions written below are either increased or stimulated by cortisol or glucocorticoids. See here, gluconeogenesis is stimulated. Now, this is the synthesis of new glucose or new sugar. So it is stimulated by glucocorticoid. So you can easily say glucocorticoid or cortisol increases blood sugar. Okay, very easy. Protein catabolism is increased. That's why there is weakness of the muscle if cortisol is excessive in the blood. Like in Cushing syndrome, there is excessive cortisol. As a result of that, the person will have muscle weakness. This is the way of correlation. Fat deposition. Now, this fat deposition is a very interesting one. This is called central adiposity. See that? Let me write that term here. Central adiposity. Now, what does that mean? The fat from the extremities, like limbs, okay, are taken towards the central part of the body, on the face, okay, on the shoulder, and on the trunk. So this is known as central adiposity. That's why the limbs of the person with Cushing syndrome look very, very thin, and the central part of the body looks fat. Another important point here is sodium retention and potassium loss. Now, think about the action of mineralocorticoid or aldosterone. So what is the function of aldosterone on kidney? Anybody? What is the function?
Sodium retention and potassium loss.
Exactly. Okay, I'm sure 100% of the students know this answer. So aldosterone is retaining sodium and excreting potassium in the kidney. Cortisol has also got aldosterone-like activity. Never forget this. Cortisol has aldosterone-like activity or mineralocorticoid-like activity. That's why sodium is retained and potassium is lost, okay, in the urine or from the kidney. Quite easy to understand. Free water clearance. Okay, free water clearance means a bit of excretion of the free water. So this action is enhanced by ADH-like activity. Uric acid production is increased and circulating neutrophils are increased. Now this is an interesting point. Let me highlight this because many of the time if the patient comes to our hospital with some fracture, some stressful situation like big type of trauma, okay, then also WBC count is high. There may not be any sign of infection in the body, but WBC count is high. So this is because of excessive cortisol secretion, which occurs as a result of stress. So what this cortisol is doing, it is migrating the neutrophils, okay, especially the neutrophils, from the margin of the blood vessel and the spleen towards the main blood stream. And when we draw blood during that time and examine for, what is the total leukocyte count and differential leukocyte count, we'll see neutrophilia. So this is not a real increase in neutrophil count inside the body. It is just migration of neutrophil from one site to the other. Okay, so let's move on. So all these actions are now decreased or inhibited. Now see this, protein synthesis is decreased or inhibited. That's why there is muscle weakness or even atrophy of the muscle. Host response to infection is decreased. Very, very important action of glucocorticoids, or I should say drawback of glucocorticoid or adverse effect of glucocorticoid, because they make the person liable to infection. They make the person immunosuppressive if we give it for a longer duration. They suppress or inhibit delayed hypersensitivity reaction. That's why if somebody is taking corticosteroid, then man-to test will be negative. Okay, they cannot form reaction against the man-to test or PPD test. Circulating lymphocytes would be decreased, and circulating eosinophils are also decreased. And this is an important point to remember, because in case of any allergic reaction, if antihistamines like drug are not working properly, the second choice for us is glucocorticoid. Glucocorticoid, because they decrease the circulating eosinophil and they can act as an anti-allergic substance. Now, these are the physiological aspect, okay, of glucocorticoid. Now, let's talk about what are the natural and synthetic steroid. What are the common one? Look at this table. Cortisol is the natural one, also known as hydrocortisone, okay, hydrocortisone. And look at the glucocorticoid effect and mineralocorticoid effect of this cortisol or hydrocortisone, 1 and 1. Now let's compare what are the strength or potency of other corticosteroid in comparison to cortisol. So prednisolone, very, very commonly used corticosteroid these days in clinical practice. This is an oral form of corticosteroid. So glucocorticoid effect is 4 times than hydrocortisone, whereas mineralocorticoid effect is lesser than hydrocortisone. See this, just 0.7 in comparison to 1. Dexamethasone and betamethasone are the most powerful form of glucocorticoid. Now see this, 40 times more potent than hydrocortisone, 40, whereas the mineralocorticoid effect is also double than cortisol. So these are very powerful type of glucocorticoid. Aldosterone is a mineralocorticoid, so glucocorticoid activity is almost nil, whereas mineralocorticoid activity is 400 in comparison to cortisol. So see this. Fludrocortisone is the synthetic one, the synthetic form of mineralocorticoid. So glucocorticoid activity is 10 times and mineralocorticoid activity is again 400. So this is a good practical type of slide to remember, and sometimes your teacher may ask you which is the most potent corticosteroid from the list. This will help you. Now we are entering into the one very important slide now, that is how our body will control the release of cortisol. Okay, so this control is done by hypothalamo pituitary adrenal axis. Hypothalamo means hypothalamus, pituitary is anterior pituitary, adrenal means adrenal gland. So they work together for the control of the release of hormone. So see here, this is adrenal gland. You can clearly see it here. Okay, so it is releasing cortisol. It is releasing cortisol. So what is the stimulant for this? ACTH. What is the full form of ACTH?
Adrenocorticotropic hormone.
Adrenocorticotropic hormone.
Exactly. Excellent. Adrenocorticotropic hormone. So name itself suggests it is stimulating the adrenal cortex. Adrenocorticotropic. Trophic means stimulation hormone. But one important point I like to highlight, there are three zones in case of adrenal cortex: zona glomerulosa, zona fasciculata, and zona reticularis. But this ACTH has predominantly, okay, stimulated zona fasciculata layer. It has a very minor effect on mineralocorticoid secretion and sex steroid secretion. This is the important point to remember. Okay, it has a minor effect. Yes, it stimulates somehow, but it is not the major stimulation at all. For cortisol, it is the major stimulation. Now see this. So cortisol is coming out, and this cortisol is giving negative feedback to the hypothalamus and pituitary. Look at this minus sign, okay, and the red, color. These are the inhibition. This is known as negative feedback of cortisol for the secretion of CRH and ACTH. The CRH, okay, is corticotropin releasing hormone. Corticotropin releasing hormone, which is released by hypothalamus. This CRH is stimulating ACTH producing cell in anterior pituitary for the more production of ACTH. Okay, so what this cortisol is doing, it is giving negative feedback so that it is blocking the release of CRH and ACTH both. In a stressful situation, there is more release, okay, more release of CRH, more release of ACTH, and more release of cortisol. That's why this is also known as anti-stress hormone. Anti-stress hormone. So we cannot cope up with the stress without this important hormone. So this is a very important function of glucocorticoid. And one more thing, circadian rhythm. So what is the relation of this circadian rhythm with glucocorticoid level? Anybody? At what time of the day or night glucocorticoid level is maximum? What time?
In morning it is
In the morning.
increased, sir. In
In morning
evening it
it
decreases.
increases.
Yeah, decrease during evening time it will
Evening time
decrease.
Yes.
Morning increase.
So I'm sure many students know this already because we have already learned this before. In the morning time, cortisol level is the maximum, and during the midnight time, okay, or you can also say during the evening time till the night time, the cortisol level is minimum. Okay, this is known as circadian rhythm. So we should note this fact, because at what time of the day or night we have taken the blood, it depends on that. Now, one more thing I like to highlight here, okay, because it will make you easy later on. Now, see this. These days, we are using a lot of steroid drug. Okay, these are called synthetic steroid, like prednisolone, like dexamethasone. So, what are they doing to this axis? See here. Okay, these drugs are just like cortisol. They are much more powerful than cortisol actually. So they are giving negative feedback to this axis. So what does that mean? They are blocking the release of ACTH and CRH. So ACTH is suppressed. Without ACTH, this adrenal gland will be atrophied. This adrenal gland will go into sleep. Okay, so it is not producing the endogenous cortisol now. So this is a very, very important knowledge to understand. Now, let me repeat again. We are giving powerful glucocorticoids from outside. They are causing negative feedback to hypothalamus and anterior pituitary, so that ACTH is not coming from above. Without ACTH, adrenal glands are atrophied. They do not produce the endogenous cortisol. Now, whenever patient is getting drug from outside, everything is fine, it doesn't cause much problem. But if the patient suddenly stops taking these powerful drugs from outside, suddenly, okay, then what will happen? Now the 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 supplementation of steroid is cut off, and the endogenous production is also cut off. There is no presence of cortisol or glucocorticoid in the body. Now this situation cannot be handled by our body, and there may be presence of shock and so many other complications. Patient may die actually in this situation. So to avoid this situation, we have to slowly taper the dose of that corticosteroid and never stop it suddenly. Now, why? What is the rationale here? We are giving this adrenal gland enough time to recover. Okay, this adrenal gland should be given time to recover back so that it will start to produce cortisol again. This is a very, very important knowledge. Okay, I have explained this before also, so please remember this. Now let's move on. So today we are going to talk about two important conditions. One is Addison's disease and another is Cushing's syndrome. Now, let's talk about Addison's disease first. This is also known as primary hypoadrenalism. Means the problem lies, okay, in the adrenal gland itself. Adrenal gland is destroyed or damaged because of some causes, and as a result of that, okay, whatever hormones are released by adrenal gland are decreased, okay, especially the adrenal cortex. In this condition, there is destruction of the entire adrenal cortex. So all the three zones are destroyed here. So the patient is having decreased level of aldosterone, decreased level of cortisol, and decreased level of sex steroid. Primary hypoadrenalism shows a marked female preponderance and is most often caused by autoimmune disease, but tuberculosis is also a very common cause. So straight away, these are the two most common causes of Addison's disease: autoimmune disorders and tuberculosis. Probably in the developing world, tuberculosis is still more common, whereas in the developing world, because the incidence of TB is less common there, probably autoimmune disease takes over. Okay, let's move on. Now, what is the pathophysiology of Addison's disease? What is really happening here? Let's talk about it. Glucocorticoid or cortisol, mineralocorticoid or aldosterone, and sex steroid like dihydroepiandrosterone or androstenedione, all of them are reduced here. All are reduced. This is a very important point to remember. This differs from hypothalamic pituitary disease, in which mineralocorticoid secretion remains largely intact, being predominantly stimulated by angiotensin II, whereas adrenal sex steroid production is also largely independent of pituitary action. That's what I discussed just now, that ACTH, which is coming from the pituitary gland, is only stimulating cortisol secretion. Others are not that predominantly stimulated. So that's why in case of hypothalamic pituitary disorder, okay, aldosterone level may be the same and sex steroid level also may be the same, because they are not affected by pituitary disorder, whereas cortisol level is severely decreased. In Addison's disease, reduced cortisol level lead, see this, levels lead through feedback to the increased CRH and ACTH level, the latter being directly responsible for the hyperpigmentation in case of Addison's disease. Now, if you have understood that, hypothalamo pituitary adrenal axis, this point is very, very clear. Here we have very low level of cortisol because adrenal gland is damaged. So decreased amount of cortisol. Decreased cortisol gives decreased type of negative feedback or poor negative feedback. That means more ACTH and more CRH is coming from above. Above means hypothalamus and pituitary. Very clear. So during investigation, this point we have to prove. We have to measure cortisol, number one. We have to measure ACTH, number two. So this is how we confirm it. And one of the important clinical feature here is hyperpigmentation in different parts of the body, especially on the scar tissue as well as in the mucous membrane. Now, why is that? Because this ACTH is stimulating melanocyte. Okay, what are the function of melanocyte?
Color, sir.
Increase color.
Okay, so you have to say it is producing melanin. Okay, melanin pigment. That melanin pigment is responsible for pigmentation of the skin. So that is the a proper answer. And this ACTH is stimulating those melanocyte for the more production of melanin. That's why the person becomes hyperpigmented. Let's move on. Now, what are the causes of Addison's disease? Now, two of the most common cause you already know, but what else? See here, these are the two more common, most common causes: autoimmune diseases and tuberculosis. Because of this point, Addison's disease is also considered as one of the example of autoimmune disorders. Don't forget that. Your teacher may ask you, what are the examples of autoimmune diseases in our body? You can very safely take this name, Addison's disease. Third one is a surgical removal. If we remove adrenal gland, then definitely there will be lack of those hormones which are coming out. Primary hypoadrenalism. Hemorrhage or infarction from meningococcal septicemia. Now, what is the medical term for this?
Waterhouse.
Waterhouse.
Very good. Very good. Excellent answer. Excellent. This is known as Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome, and this is caused by Neisseria meningitidis. Neisseria meningitidis, the same organism which causes meningitis. Okay, which causes meningitis. Now, this is a very fatal type of disease, and within very short duration, like within 24 to 48 hours, the patient will develop septic shock. And if we fail to diagnose in time, patient will die. Another one is infiltration. Now, infiltration by malignant tumors and amyloid. Okay, the common one. Malignant destruction means metastasis of the malignant tumor to the adrenal gland can destroy it. And amyloid is an abnormal protein which is present in the body in response to chronic inflammation and infection. It is a protein formed by liver. One of the rare conditions is known as adrenal leukodystrophy. Adrenal leukodystrophy. This is a rare situation where, okay, very long chain fatty acids are accumulated. Very long chain fatty acids are accumulated. Just know this much. And this is not a good situation to have. They will block the synthesis of hormones when they are collected inside the adrenal gland. That's why Addison's disease occurs. And central nervous system or brain is also affected in this situation. The myelination in the brain cannot occur properly in adrenal leukodystrophy. So all those conduction of the signal, development of the brain and things like that will be affected. Now, what are the clinical features of Addison's disease? What happens to the patient? Let's talk about it. The symptomatology of Addison's disease is often vague and non-specific. So there are lots of vague and non-specific features. There is one important condition known as Addisonian crisis. Okay, Addisonian crisis, and I have already explained this actually. This is a very serious condition where there is a lack of glucocorticoid hormone inside the body, okay, because of different reason. Now, look at this reason. They may be precipitated by intercurrent illness, accident, or operation, where our body demands more presence of cortisol, but our adrenal gland cannot produce that amount of cortisol. As a result of this, the person may suffer from severe hypotension and dehydration, and there may be death. Another reason for this, if patient is taking powerful glucocorticoid from outside, and if they suddenly stop taking it, okay, same type of situation will develop because there is no presence of glucocorticoid in the body now. This is also known as Addisonian crisis. Now, another important clinical feature is pigmentation. Okay, this is dull to gray brown or even black pigmentation is a predominant sign in over 90% of the cases. And the reason I already explained to you, the ACTH, which is present in excessive amount in case of primary hypoadrenalism or Addison's disease, is stimulating the melanocyte to produce more melanin. Another important clinical feature is a systolic hypotension in the postural form. Okay, in the postural form. What does that mean? During the standing, okay, the person feels dizzy because of decrease in blood pressure. This is known as postural hypotension. Now, the reason for this is due to hypovolemia and sodium loss. And this is present in case of Addison's disease. Mineralocorticoid deficiency is the cause of hypotension here. Remember, the whole adrenal cortex is destroyed here. So mineralocorticoid is also affected. Now look at this picture. This is a very easy one for you. This is the features of Addison's disease, are also known as chronic hypoadrenalism. See here, these are the features of hypoaldosteronism. Hypoaldosteronism means decreased level of aldosterone hormone. It leads to low serum sodium, high serum potassium, okay, because potassium cannot be excreted out, isn't it? And sodium cannot be retained because aldosterone hormone is low. So very easy to understand, leading to dehydration, okay, low extracellular volume and total blood volume, both are low. Postural hypotension occurs quite commonly. Weight loss because of dehydration and fluid loss, and there is high plasma renin because of low negative feedback, okay, and all those things are there. Or because of the compensatory mechanism also, you can give that type of reason here. Now, because of low cortisol, what happens? Hypoglycemia. Now, why blood sugar level decreases in a low cortisol level? What is the reason?
No, gluconeogenesis.
Gluconeogenesis is not.
There is no
Gluconeogenesis occur.
No gluconeogenesis.
Very good. Gluconeogenesis doesn't occur, if cortisol level is low. So it is decreased, resulting in hypoglycemia, especially if the patient is fasting. Or you can also answer in other way. A cortisol or glucocorticoid is counter-regulatory hormone, okay, for insulin. The effect is exactly opposite to the insulin. Insulin decreases blood sugar, but it increases blood sugar by this different mechanism. It can also stimulate glycosinolysis. Hypercalcemia and anemia, okay, occurs here. Hypercalcemia because of calcium resorption, high ACTH, and this melanocyte stimulating hormone, actually ACTH stimulating or acts like that, You understand like this. ACTH acts like melanostimulating hormone for melanocyte, okay, leading to pigmentation. If sex hormones are low, there is loss of body and pubic hair, because these hairs are grown in response to sex steroid which are coming out from our adrenal gland, especially okay axillary hair and the pubic hair. They are grown in response to adrenal steroid. Loss of libido and amenorrhea, even muscle wasting and thin limbs, all these are because of low sex steroid. This is excellent slide which tells us all three important hormones are low in case of Addison's disease and what are the clinical features. Let's move on. Now these are the general or overall clinical features. Okay, we can discuss in any way in the exam. You don't need to repeat. If that picture was or drawn and explained like that, you don't need to repeat this again. It's up to you. Okay, but for the repetition is so important to understand in medicine. The more we repeat, the more easily we get it. That is the way. So common symptoms are weight loss, anorexia, malaise, weakness. These all are very non-specific. Depression, okay, impotence and amenorrhea, nausea, vomiting, diarrhea, confusion, syncope from postural hypotension, abdominal pain, constipation, and myalgia. So many of them are very non-specific, even difficult to give reasons why are they occurring, because of so many interlinking process or phenomena they are occurring here. Now, the signs are important for the diagnosis. All of you, please pay attention. Pigmentation is one of the most important clinical feature here, okay, especially of the new scar and palmar creases, but they also occur inside the oral cavity, known as buccal pigmentation. So we have to examine the oral cavity properly. There is postural hypotension. We can prove that by taking blood pressure in different position, on the supine position as well as standing position. And in standing, it drops by more than 10 to 20 millimeter of mercury, the systolic blood pressure. Loss of weight, general wasting, dehydration, loss of body hair as a result of decreased androgen, and vitiligo. This is just an association, because vitiligo is the marker of autoimmunity. We're talking about the clinical features of Addison's disease. Now look at this picture here. This picture is all about the hyperpigmentation in case of Addison's disease. Look at the hyperpigmentation at the margin of the gum and the teeth. Okay, gum as well as teeth. Look at the back of the elbow, which are having excessive pigmentation. These are the palms. The palmar creases are some area where pigmentation is very commonly seen, and you can see the association known as vitiligo in this patient. Vitiligo, though directly it is not a clinical feature of Addison's disease, but vitiligo is known as marker of autoimmunity. Okay, marker of autoimmunity. That means the same patient may be having different types of autoimmune disorder. So this is the way you explain here. Now, after clinical features, let's talk about how to confirm the diagnosis. What are the investigations we like to do? First is single cortisol measurement. Now, in this case, cortisol is decreased. We all know that. Okay, cortisol is decreased. This is a case of Addison's disease. So it is of little value, although a random cortisol below 100 nanomole per liter during the day is highly suggestive, and a random cortisol more than 550 nanomole per liter makes the diagnosis unlikely. So what does that mean? If there is a high level of cortisol, then this cannot be the diagnosis, because it cannot happen here. Okay, this is a condition where cortisol level should be low. But sometimes a random cortisol below 100 nanomole per liter, okay, during the day is also highly suggestive. There are some better investigation than this. Okay, let's talk about it. Another one is a short ACTH stimulation test. Now, this is a sometimes asked in the Viva exam for the students. So let me explain this. The short ACTH stimulation test, okay, is done like this. Blood is drawn in two separate tubes for baseline cortisol and aldosterone value first, okay, without stimulation. What is the level of cortisol and aldosterone? We detect that first. After that, 1 microgram of ACTH is used, and the test lasts 1 hour, just 1 hour. That's why it is known as short ACTH stimulation test. 30 or 60 minutes after the ACTH injection, 2 more blood samples are drawn just to make sure what is the level of cortisol and aldosterone now after the stimulation. And you have already the baseline, so you can compare. In normal case, okay, the cortisol level should double from a baseline of 20 to 30 microgram per dl within 60 minutes. Because we are giving ACTH, and in normal people, this ACTH will stimulate the secretion of cortisol so that it will get doubled. Quite easy to understand. But what happens in case of Addison's disease? So note that an absent or impaired cortisol response confirms the presence of primary hypoadrenalism or Addison's disease. Okay, baseline cortisol is well below 10 microgram per dl in this case, or even if it rises no more than 25%. That is still considered a very less rise. So what is the concept here? Okay, let me make it very simple for you. In this case, the adrenal gland is damaged. Okay, so even after the stimulation, it will not produce cortisol. This we need to prove it, and this proof is provided by short ACTH stimulation test. Whereas if this is a case of secondary problem in pituitary gland or hypothalamus, there is a large fold increase occurs after ACTH stimulation test because adrenal gland is intact. Okay, the problem doesn't lie in adrenal gland itself. The problem lies in the pituitary or hypothalamus. So if ACTH is provided, that adrenal gland can produce an increased amount of cortisol. Let's move on. Now, okay, this is the slide which is telling you about these conclusions, okay, and the interpretation. See this, pre-ACTH cortisol less than 20, post-ACTH cortisol is also less than 20. Aldosterone is also less than 20, and post-ACTH aldosterone is also less than 20. What does that mean? This is a case of primary hypoadrenalism or primary hypoadrenocorticism. Okay, because both cortisol and aldosterone are decreased even before stimulation and after stimulation. Clear-cut case. Now the second one, pre-ACTH, the cortisol is less than 20 nanomole per liter. Post-ACTH is also 20, whereas aldosterone is normal. See this, okay? So this is consistent with secondary hypoadrenalism, or when the person is taking exogenous glucocorticoid, including topical skin, eye, and ear preparation. Now, a little bit of confusion has crept in your mind, I'm sure about it. I just now told you adrenal gland is normal in this secondary or pituitary type of disorder. Then even after giving ACTH, why the cortisol is still less than 20? Okay, that is a very, very good question to ask to yourself. Now listen for the answer. In acute condition, okay, the disease has just started. Okay, probably this is not the reading. The reading will be more here. Okay, because the the adrenal gland is still normal. It is not yet atrophied. Whereas in chronic cases, because of long-term absence of ACTH, the adrenal gland is already atrophied. So even after giving ACTH, that adrenal gland may not produce enough level of, cortisol. So it depends how chronic is the problem. What are the other investigation we like to do? See this serum aldosterone level. We have to measure it. We already did that in the last slide. Is reduced with high plasma renin activity. Usually reduced, okay? Not always though, because the aldosterone, it is in let's explain like this. In case of primary primary hypoadrenalism, I should say, all three hormones are decreased. But what about in secondary problem, which lies in the pituitary or hypothalamus? Probably in that case, the aldosterone level is not very affected because it is not depending on ACTH stimulation. That's what I want to say here. Anemia is seen after rehydration, okay, because there is sudden dilution after rehydration, so anemia is obvious. Hyponatremia and hyperkalemia and high urea can be seen, but they can be normal in the beginning. Blood glucose may be low with symptomatic hypoglycemia. This is all because of very low cortisol. Now, this is a type of autoimmune disease. So adrenal antibodies are present, and we can detect that by investigation. Adrenal antibody. Chest and abdominal X-ray may show evidence of tuberculosis or calcified adrenal gland, which are very, very important finding in tuberculosis. So we need to find, because TB is one of the commonest cause of Addison's disease. 9 AM plasma ACTH level, okay, is measured, and a high level, that is more than 80 nanogram per liter, with low or low normal cortisol, confirms the diagnosis of primary hypoadrenalism. Now let me explain once again, because a little bit confusing for the student. See this, we are measuring it at 9 AM, means in the morning time, and in the morning time in the normal person, okay, cortisol level should be maximum. Cortisol level should be maximum. But this is a case of Addison's disease or primary hypoadrenalism. So in this case, cortisol level should be low. Okay, it should be low. As a result of low cortisol, there will be poor negative feedback. So ACTH level is high. See this? If you follow the normal points, explanation is very easy. A long ACTH stimulation test can also exclude adrenal suppression by steroid or ACTH deficiency. So this is exogenous administration of steroid, which can be diagnosed by long ACTH stimulation test. Now, the final part of this topic is the management. Management of acute hypoadrenalism, how we do it. Now, look at the common problems in acute hypoadrenalism. These are the hypotension, hyponatremia, hyperkalemia, hypoglycemia, and dehydration, often with precipitating infection, trauma, or operation, where our body demands more cortisol, but that is not happening in case of Addison's disease. So these are the common problems. So how we tackle it? We have to tackle the hypotension first. We have to bring back this blood pressure back to the normal, and this is done by crystalloid. Okay, done by crystalloid, 0.9% normal saline, 1 liter of 0.9% normal saline, or even lactated ringer should be given over 30 to 60 minutes with 100 milligram of intravenous hydrocortisone. So this is how we start to treat this acute hypoadrenalism. We have given hydrocortisone or cortisol as well as fluid. Now, after that, we have to give several liters of normal saline or lactated ringer within 24 hours. It depends on the rehydration level of the patient, and that is judged by pulse volume, blood pressure recovery, and central venous pressure. Okay, and after that, we continue to give hydrocortisone 100 milligram intramuscular every 6 hourly until the patient is clinically stable. Because this is a disease where cortisol level is very low, so hydrocortisone is routinely given from outside. Hypoglycemia, if it is there, we have to give glucose. Now, what about the oral replacement medication? See this? After that, after the patient is stable and after we can discharge patient from the hospital, we keep the patient on oral medicine. Okay, initially hydrocortisone 8 hourly, and we reduce it 20 to 30 milligram in divided doses over a few days. Fludrocortisone is unnecessary acutely, as the high cortisol does provide sufficient mineralocorticoid activity. Remember that slide where we have discussed hydrocortisone has also certain mineralocorticoid activity. So when the patient is at hospital, you don't need to supplement the separate mineralocorticoid drug. But after the patient is discharged, and probably after you start to use the oral, maybe hydrocortisone or maybe prednisolone or some other type of corticosteroid, okay, then you need to think about fludrocortisone. Okay, so let's move on. Now, what is a chronic long-term management? Chronic means long-term management. Remember, sometimes what happens? The adrenal glands are destroyed by tuberculosis or autoimmune mechanism. So long-term treatments are necessary. This is done with replacement glucocorticoid and mineralocorticoid. Tuberculosis must be treated if it is there, and dehydroepiandrosterone replacement has also been advocated if there are loss of secondary sexual characteristics, okay, and loss of libido, amenorrhea, and those type of problem. Then we need to even think about replacing this type of sex steroid. Now, for this purpose, a fludrocortisone is important. Okay, fludrocortisone is important. Now, there is a small topic before we go into the Cushing syndrome. Okay, there is a small topic which is known as secondary hypoadrenalism. Remember, this is not known as Addison's disease. Okay, it manifests almost similar to Addison's disease, but it is not called Addison's disease because Addison's disease means primary hypoadrenalism. This is a secondary one we are talking here. So this may arise from hypothalamic pituitary disease because of inadequate ACTH production, or from long-term steroid therapy, which leads to this axis suppression. Very easy mechanism. If hypothalamus and pituitary are damaged, they cannot release CRH and ACTH. So adrenal gland is suppressed, number one. Number two, we are giving prednisolone, dexamethasone, betamethasone, clobetasol, those type of drugs for a long time from outside. They definitely give rise to adrenal suppression. The most common cause these days is a long-term corticosteroid medication for non-endocrine diseases. Now, you can give different example here, like bronchial asthma is treated by corticosteroid these days. Connective tissue disorders are treated by corticosteroid. Nephrotic syndrome is treated by corticosteroid. So these are some of the examples you can mention here. The long ACTH stimulation test, okay, should demonstrate a delayed and poor cortisol response in secondary type of hypoadrenalism, because there is a high chance of adrenal glands atrophy in case of long-term use of the medicine. If it is a short-term use of the medicine, the adrenal glands is still not atrophied, so it will show the good response. So this is about second